Good afternoon, everyone, and welcome. Thank you for joining us today. For those I haven't met, I think I know most of the people here, but I'm Nivi Patel. I'm a hospitalist at Oakville, and I'm very excited to welcome all of you to the very first session of our Lifestyle Medicine series, which is a monthly webinar initiative designed to support all of us in primary care with evidence-based practical approaches to lifestyle medicine. As we all know, lifestyle plays a big role in chronic disease prevention and management. This series will explore how the 6 pillars of lifestyle medicine, so nutrition, physical activity, sleep, stress management, social connection, and reduction of risky substances, can be integrated into clinical practice to improve our patients' outcomes. Today's session is a highly pertinent topic: the long-term health consequences of polycystic ovarian syndrome and the significant impact that lifestyle interventions can have on enhancing overall health. We're thrilled to have Dr. Amandeep Thakkar join us and present for us today. Dr. Thakkar has been practicing as a hospitalist at Oakville Trafalgar Memorial Hospital for over a decade now and has a women's health practice in Oakville. She completed her medical degree at the University of Toronto and residency training in family medicine at Queen's University. She has additional training in integrative medicine, completing a fellowship at the University of Arizona. Integrative medicine emphasizes lifestyle medicine to improve health outcomes. She is an assistant clinical professor at McMaster University, where she enjoys teaching medical students and residents. Dr. Thakkar is committed to providing comprehensive and evidence-based care to women of all ages. At her women's health practice, she has a special interest in managing PCOS, menopause, PMS, PMDD, and contraception. Thank you again for being here, and with that, I'll turn it over to Dr. Thakkar.
Thank you so much, Dr. Patel, for the kind introduction, and thank you to CCHOHT and for supporting this talk. I really appreciate it. And thank you to everybody who's joined. Feel free to turn off your cameras, enjoy your lunch, and hopefully this is an enjoyable talk. So today we're going to be talking about PCOS and the long-term health consequences of PCOS and the impact of lifestyle. So in terms of the objectives, what we want to do is understand that lifestyle intervention is a core focus of PCOS management, and also appreciate the long-term sequelae of PCOS, which includes increased risk for cardiovascular disease, type 2 diabetes, obstructive sleep apnea, and endometrial cancer. And then I will spend some time towards the end reviewing pharmacological treatment options as supported by the updated 2023 PCOS guidelines. Given the time for this talk, I won't be focusing on fertility management during this presentation, but definitely that is a very important piece of PCOS management. So let's get started. So Polly comes to your office. She's a 26-year-old woman that is having irregular cycles. She said over the past year, she's having a period every 3 to 4 months, with one cycle that was 6 months apart in the past year. And her last menstrual period was about 4 months ago. She's also reporting mild to moderate facial hair, no hair loss at the top of the head, but she does report excessive hair growth on her face and her body. And in fact, she's having to shave her face and chin almost every other day, which is quite distressing to her. She is completing a postgrad program at her university, and during this time, she reports increased stress due to academic stressors and weight gain of about 15 pounds. And then she points towards her neck, and she shows you this kind of dark rash kind of in the folds of her neck that it appears thick and velvety. So you go ahead and you do a physical exam. You notice her blood pressure is 130/77 and that her BMI is elevated. You look to kind of objectively quantify hirsutism using the modified Fairman-Galloway score. And given that she's been shaving, you do pull up a picture and you're able to calculate a score of 12 with Polly's help. She also has evidence of mild to moderate facial acne, and what you see on her neck and axilla is acanthosis nigricans. So you send her for further lab testing and pelvic ultrasound to work up her irregular cycles and other symptoms, and you give her a prescription for Provera, 10 milligrams for 7 days to induce withdrawal bleeding. As you remember, her last period was about 4 months ago. So you see her in follow-up 2 weeks after, and she did go for transvaginal ultrasound. And the finding is that the ovarian volume is increased bilaterally, so 12 cc's on the right and 9.8 cc's on the left, and that there are 20 follicles present on either ovary, and these are sub-centimeter follicles. With respect to lab testing, you see that her total testosterone is elevated at 2.2, DHEA is 12.4, and that her LH to FSH ratio is elevated with a ratio of 3:1. You have also sent her for thyroid testing, prolactin level, and a 17 hydroxyprogesterone to rule out other causes of irregular cycles, and her estradiol level is within normal. You did do a beta, which is negative, so pregnancy does not explain her presentation. Given your concern for acanthosis nigricans, you did check her A1C, which is 5.6%, and you also sent her for an oral glucose tolerance test, which demonstrates impaired glucose tolerance. So based on all of this, you counsel Polly that her diagnosis is PCOS, and you stress the importance of lifestyle, including managing her diet, physical activity, stress, and sleep. At this time, Polly does not want to start any prescription medications. She's quite surprised by her diagnosis. She's heard about PCOS, and so she wants to, go online and learn more about it. And you did talk to her about some prescription medications that she could consider, but she's just really not interested at this time. So let's do a quick brief overview of PCOS. So we know it's a very common endocrine disorder affecting about 10% of women of childbearing age. It's a chronic disorder, meaning that once you're diagnosed with it, these symptoms and the syndrome stays with you for a lifetime. It can manifest as irregular cycles, symptoms of hyperandrogenism, and often PCOS goes undiagnosed. And there's also delay in treatment after diagnosis. And so in terms of the pathophysiology of PCOS, there are theories of what is causing PCOS. And what we think is happening is that there is an abnormal pulsation of GnRH at the level of the hypothalamus, which is actually an increased frequency of pulses. And when this acts at the level of the ovary, the granulosa and theca cells will produce an elevated ratio of LH to FSH. And so this causes abnormal ovarian function and an ovary that produces more androgens. It also causes this polycystic ovarian morphology, which is actually not cysts, but they're just multiple follicles out of which there might not be an egg released, which is causing ovulatory dysfunction. With the hyperandrogenism, this causes an impact on insulin at the level of the pancreas, and there is an insulin resistance that actually has a bidirectional relationship with hyperandrogenism. So one affects the other. At the level of the liver is not producing an adequate amount of sex hormone binding globulin, and this increases the level of androgens. So it's almost like a vicious cycle of what's underlying the manifestations of PCOS. In terms of the most accepted criteria to diagnose PCOS, it would be the Rotterdam criteria. And PCOS is diagnosed when 2 out of 3 criteria are met and all of the other diagnoses are excluded. So it's important to remember that PCOS is a diagnosis of exclusion. So In terms of the three criteria, we have irregular cycles, either blood work that shows hyperandrogenism or clinical hyperandrogenism, and polycystic ovarian morphology. And I'll briefly just touch upon the different criteria. So when we say irregular cycles in adult women, we mean cycles that are either less than 21 days or greater than 35 days apart, having less than 8 menstrual cycles per year, or having more than 90 days for any one menstrual cycle. Or you might be noticing the patient is having bleeds at regular intervals, but those cycles are anovulatory. In terms of hyperandrogenism, we can fulfill this criteria in either seeing it in blood work or seeing it clinically. So in blood work, what we can test for are serum total testosterone, free testosterone, so that's the amount of testosterone that is unbound, and then you can check for DHEAS or androstenedione. When we see elevations in PCOS in these androgens, we typically see elevation that is on the upper limit of normal or just slightly above that. If your patient is having a testosterone level that is quite elevated, so more than 5.2 millimoles, or DHEAS that is above 18.9 millimoles, you should be thinking about other causes that could be causing elevated androgens. So something like an androgen secreting tumor, ovarian PCOS in older women. So these are things that need further thinking. In terms of clinical hyperandrogenism, we can see this manifest as female pattern hair loss, acne, and hirsutism. And in fact, hirsutism is the most specific sign of hyperandrogenism. And the way we evaluate for hirsutism is using this diagram here, which is the modified Ferriman-Galloway score. And so what this is looking at is 9 different areas of the body and giving it a score from 1 to 4, with the highest score being 36. Anything above 8 would be significant for hirsutism. So you can say there is clinical hirsutism present. Having said that, this scale is quite challenging to use because often patients have modified their aesthetic by undergoing hair removal. So often what I will do with patients is just have them look and they can identify, where they think their hair growth is, because it is difficult to clinically evaluate. Now, there is no objective scale for acne, but there is an objective scale for female pattern hair loss, which is the Ludwig or Olsen visual scale. So using these tools can help us quantify objectively clinical manifestations of hyperandrogenism. For polycystic ovarian morphology, so this is often not well understood by patients. They think that commonly what I see is a patient believes that their ovaries are just full of a whole bunch of cysts, right? You would think with a name of polycystic ovarian syndrome that that's what you have on your ovaries. And I often explain to them that you do not have ovarian cysts, but what we are seeing is multiple follicles. And as you can see in the ultrasound photo here, the follicles are on the periphery, they're sub-centimeter, and so with using transvaginal ultrasound, the radiologist should be able to quantify follicle number per ovary. If it is above 20 follicles, it would be positive for a polycystic ovarian morphology. This has been updated since the previous guidelines, which would ask for a follicle count greater than 12. And the newest thing in the guidelines is using anti-Müllerian hormone. So this is from the updated 2023 guidelines that in adult women, we can use on anti-Müllerian hormone to fulfill the criteria for polycystic ovarian morphology. We often don't do that in Ontario because there is a cost to AMH, and it is also not recommended in adolescents. Nor is ultrasound recommended in adolescent women because often multiple follicles is a normal finding in adolescent women. So in terms of initial investigations and differential diagnosis of PCOS, this would be maybe a good starting point in terms of lab investigations and transvaginal pelvic ultrasound. So making sure to exclude thyroid disease, prolactinoma, trying to quantify your androgens, and then a 17-hydroxyprogesterone will rule out congenital adrenal hyperplasia. This test is often done in the follicular phase while the patient is fasting. And then a transvaginal pelvic ultrasound if it is a woman who is post-menarche over 8 years. So there are many different phenotypes of PCOS because it is a syndrome, and you only need 2 out of 3 criteria to fulfill a diagnosis of PCOS. The first 3, so A, B, and C, are associated with hyperandrogenism. And it is really these first A, B, and C, these phenotypes that are associated with long-term complications. For phenotype D, which is non-hyperandrogenic PCOS, typically the long-term sequela in terms of metabolic and cardiovascular complications is less significant. So let's talk about those. PCOS, as this diagram illustrates, is a full body process. So it's not just having, changes in your menstrual cycle and having features of hyperandrogenism, but it's also having increased risk for things like insulin resistance, type 2 diabetes, metabolic syndrome, as well as increased risk for things like heart attack and stroke. We know these women are at higher risk for obstructive sleep apnea, as well as depression, anxiety, and disordered eating. And a very important other complication is that of endometrial cancer. So I'll go into these a little bit more. If anybody has questions, feel free to ask in the chat box. I think we're okay.
Mm-hmm. Yeah.
So in terms of the insulin resistance, if you remember back to the pathophysiology slide, there is a bidirectional relationship between hyperandrogenism and the elevated level of insulin. And so if you compare PCOS women with normal controls, you could see that the increase in blood glucose on the left graph is about the same. But in women with PCOS, you could see on the right side, the insulin response is manyfold that of a normal control. So this is what we say. I think we have an overhead announcement. So this is where we see that hyperinsulinemia in PCOS. With respect to long-term sequela of insulin resistance, we can see that metabolic syndrome is more prevalent in women that have PCOS compared to control. And this increases as women age, so women with PCOS age. And again, PCOS is a lifelong disease. So as we get older, these patients, we notice, are having increased cardiovascular events, type 2 diabetes, glucose intolerance. And early on, what we might be detecting is more so related to clinical hyperandrogenism and fertility concerns. In terms of prevalence of pre-diabetes and type 2 diabetes in PCOS, we can see using different criteria for defining PCOS that women with PCOS have a higher prevalence of pre-diabetes as well as a higher prevalence of type 2 diabetes. In terms of incidence of cardiovascular disease, women with PCOS are more likely to use antihypertensive medication, cholesterol-lowering medication. There is a higher incidence of metabolic syndrome as well as major adverse cardiovascular events, so increased risk of heart attack and stroke. And this slide demonstrates the same, which is that there is a greater hazard ratio for cardiovascular events in women with PCOS. With respect to obstructive sleep apnea, I found this study that was quite interesting, that women with PCOS actually have higher incidence of sleep apnea irrespective of BMI. So even if you adjust for BMI, women with PCOS will still have a higher risk of developing sleep apnea. So how can we screen for these long-term complications of PCOS? In terms of hypertensive disorders, checking and monitoring blood pressure would be quite important in these women, especially during pregnancy. In terms of glucose intolerance, the 2-hour 75-gram oral glucose tolerance test is the preferred test over A1C and PCOS. And the reason for this is that the oral glucose tolerance test will be able to detect impaired glucose tolerance over an A1C. So it just gives us a little bit more information about how the body is handling that glucose load, which might not be reflected in an A1C. With respect to cardiovascular risk, monitoring their waist circumference, lipid profile would be recommended, as well as using something like the Epworth Sleepiness Scale for screening for obstructive sleep apnea. So let's talk a little bit about lifestyle management. So as the PCOS updated guidelines suggest, that lifestyle management is a core focus in PCOS. And what I find is quite interesting is this evolutionary model of the pathogenesis of PCOS. So when we look at compare the ancestral environment, so before industrial societies were created, what the theory suggests is that women that had PCOS were at an advantage in this environment, because what PCOS phenotype and the syndrome provided was an adaptive survival response. And so you can imagine if you're, in an environment where, a lion is attacking you and you really have to, work hard for your food, otherwise you would starve. Having a PCOS makeup can be a survival advantage. So if you do have insulin resistance and this is keeping up your blood sugar, this can be an advantage during a period of famine. Having hyperandrogenism can be helpful in terms of strength and fitness in this type of environment. And having a makeup that helps you hold on to more energy can increase your survival chances, as well as decreased fertility can often improve a woman's lifespan in the kind of ancestral environment. Now you take this same kind of makeup and you put us in a Western diet where you have the standard American diet, you might have some gut dysbiosis, the overall amount of physical activity you're getting is quite low, and you have endocrine disruptors in the environment, as well as psychological stress. We might notice a very maladaptive survival response. So those same things that helped us back in the ancestral environment are no longer physiological, but they're pathological. And this is kind of what we see in terms of the downstream sequela of insulin resistance, hyperandrogenism, enhanced energy storage, manifesting as metabolic disease and obesity, and decreased fertility, requiring a need for fertility treatment. I think we have a question.
There's a comment. Yeah, I was just going to say there's a comment in the chat. I'll just read it out. So appreciate your presentation. Years ago, I added insulin levels to the glucose tolerance test, and this has been very helpful clinically. I find this much more informative than just the glucose tolerance test. The patient also has more understanding of her disease as the level drops and they become better.
That's amazing. Thank you for sharing that. Yeah, definitely. The A1C doesn't tell us the full picture in PCOS, and so the glucose tolerance test can be quite helpful. And then there is some evidence that's evolving in terms of using insulin to help further management and to help with patient education. For the current guidelines, they do not recommend using insulin levels to guide management. And that's because there are so many different assays and things have not been standardized, but that would be definitely an area of future research. But I really appreciate the comment there. Okay. So in terms of lifestyle advice in PCOS, there's a lot of information and a lot of misinformation that your patients might be coming in with. And so the top pie charts just look at when diet and physical activity is recommended by a healthcare professional. The majority of that is coming from a physician. So that's when we as family physicians and kind of the front line are very important in terms of educating our patients with lifestyle advice. In terms of alternative sources, you can see the rest of the information, as with many other medical conditions, is coming from the intranet and social media. And this is why some of your patients might be walking in with different ideas about PCOS, that, I should be going on a gluten-free diet or a dairy-free diet. I have to do HIIT training. That's the best for my PCOS. Or you'll hear the opposite, which is HIIT is bad for your cortisol and it will just make my PCOS symptoms worse. So let's have a look at the evidence around lifestyle in PCOS, and also have a look at why the guidelines suggest what they do. And so let's look at diet and the outcome on PCOS outcomes. So there's a meta-analysis that was published in 2023, and the findings were used to inform the PCOS guidelines. And here you could see there's different dietary interventions that look at different PCOS outcomes. And so here they're evaluating the effect of a low glycemic index or a low glycemic low diet on PCOS, and they do see improvement in things like waist circumference, BMI, insulin sensitivity, glycemic control, and lipid profile. They've also looked at high protein diets, and they also find positive outcomes such as it improving satiety, improving fasting blood sugars and insulin, as well as improving androgen levels. In terms of fat intake, they were able to see an improvement in metabolic parameters when patients consumed a diet that was high in mono and polyunsaturated fats compared to saturated fats. In terms of other diets, they evaluated things like the DASH diet, plant-based diet, as well as a vegan diet. And what the findings were that diets that are high in fiber and plant proteins will allow an improvement in metabolic and hormonal profile. And the theory behind this is that these diets can help with prebiotics and improve the gut microbiota, which can be a kind of underlying mechanism that is also contributing to PCOS. They studied meal pattern and timing, and they found that there is a benefit of smaller, more frequent meals in terms of improving insulin sensitivity and fasting insulin, as well as having a large breakfast, smaller lunch, and dinner, which is being the smallest meal of the day, to help with insulin sensitivity. And so in terms of counseling patients, one approach you might use is educating them about the Mediterranean diet. And so the Mediterranean diet incorporates aspects of what I just discussed, making sure that it's a low glycemic index, as well as high protein, and incorporating healthy fats. And so I often use this pyramid to just talk about what that kind of diet might look like. The other approach that I find is helpful for patients is to just take a balanced plate approach. So I often discuss the importance of vegetables being half of the plate, 25% being a source of a good whole grain, and 25% being a lean protein, whether that is meat or a meat alternative. In terms of the official guidelines, there is no evidence to support any one type of diet composition over another for metabolic, hormonal, or reproductive outcomes. So this is to say that the guidelines don't say that a DASH diet is better than a paleo diet, is better than a Mediterranean diet. The general principles are there, but they don't recommend any specific diet over the other. But they do say to follow healthy eating guidelines. In terms of importance of helping patients stick to healthy eating, the recommendation is to tailor that eating style to an individual's preferences and goals. So the idea here is that we want to have sustainable eating. We should not be signing up our PCOS patients for a particular diet, but rather it should be a lifestyle, something that is sustainable and that they can continue on the long term. Let's have a look at physical activity and PCOS outcomes. So the meta-analyses here were able to find that aerobic exercise is helpful for improving insulin resistance and insulin sensitivity, lipid profile, fat percentage, waist circumference, VO2 max, BMI, and also can help with menstrual regularity and ovulation rates. With respect to resistance training, the finding was that it actually increases BMI, which might be that a BMI is just not a great measure of somebody's body composition. If somebody increases their muscle mass, they might have a shift in their BMI towards it being increased. Resistance training can help to decrease waist circumference as well as reduce body fat and increase lean muscle mass. And there's mixed results in terms of how it might affect androgen levels. There was a lot of interest in just using HIIT, so high intensity interval training alone in PCOS patients, and there is evidence that it does improve insulin resistance and BMI. The other finding is that diet and exercise will, compared to exercise alone, will result in greater reduction in BMI, waist circumference, fasting insulin, and insulin resistance. So in terms of the guidelines, the recommendation is that if you are trying to be kind of at steady state and not have any further weight gain, then the recommendation is more than 150 minutes of moderate aerobic activity or more than 75 minutes of vigorous aerobic activity per week. If you are trying to lose weight or regain weight that you've lost, then the recommendation is more than 250 minutes of moderate aerobic exercise per week or greater than 150 minutes of vigorous intensity aerobic exercise per week. And to also incorporate 2 days per week of strength training. Let's talk a little bit about psychological interventions on PCOS outcomes. So diet and physical activity are definitely pillars of lifestyle, but they also have studied interventions such as counseling, cognitive behavioral therapy, mindfulness, meditation in people with PCOS. And they do find that there's an improvement in depression, anxiety scores, there's improvement in sexual dysfunction, as well as negative body image and disordered eating, which are all very prevalent in PCOS. Combining CBT with the lifestyle modifications in terms of diet and physical activity changes has the greatest improvement in quality of life for women with PCOS. We can also just look at sleep in PCOS. So also another important pillar of lifestyle and a pillar of health is sleep. And we know women with PCOS do have sleep disturbances. So whether it's poor quality sleep or restless sleep, fatigue during the daytime, difficulty with initiating and maintaining sleep, and as I had mentioned in previous slides, there is an increase in obstructive sleep apnea incidence. When we have disturbed sleep in PCOS, this is going to be associated with weight gain, insulin resistance, increasing incidence of metabolic syndrome, and impaired glucose tolerance. So it is very key to optimize sleep by promoting healthy lifestyle change in PCOS. And this is actually an area of research, an area where further research is needed to see whether cognitive behavioral therapy or cognitive behavioral approaches can be helpful in optimizing sleep. So an approach would be something like CBT-I, which is CBT specifically for insomnia and sleep. In terms of kind of the underlying pathophysiology of why sleep is disrupted in PCOS, we think this is due to hormonal derangements. So Reduction in estrogen, progesterone, and melatonin levels have been characterized in women with PCOS, as well as the elevated androgen levels. And this can be disrupting the circadian clock in PCOS. And so when we do actually study the clock genes in PCOS, we see that there is a disruption in the circadian rhythm of granulosa cells in the ovary. And so this might be an explanation as to why sleep is disrupted in PCOS. And let's talk a little bit about integrative modalities in PCOS. So the meta-analysis did study many complementary and alternative and integrative therapies on PCOS outcomes. And I think this is important because we often do find in family practice that our patients do come to us, especially young patients who do not want to be on prescription medications, and they are looking for, something that is more, quote, natural, or, something that they think might have less side effects. So it would be important to kind of review the evidence around this. And so one supplement that does have good evidence for it is inositol, which is a vitamin B8 derivative. And the study dose is 2 grams twice a day. It does come in 2 different isomers. So it's myo-inositol and D-chiro-inositol. The ratio that was studied was 40:1. And there is some evidence to suggest that this can improve ovulation and menstrual regularity as well as hormonal profiles. In terms of the PCOS guidelines, inositol is recommended as an experimental therapy. And so it's important that you do counsel your patients about the evidence and the quality of evidence around inositol. But often, it is a benign treatment with very minimal adverse effects or side effects. The second one I wanted to highlight here is vitamin D. And there is a finding that PCOS women do tend to be vitamin D deficient, and correcting that deficiency and supplementing with vitamin D can often improve insulin resistance and insulin sensitivity, as well as lipids and androgens. So all of the lifestyle advice sounds wonderful, right? Adhere to a whole food diet, fix your sleep, move more, and manage your stress is what we want to tell our patients. But as we all know in real life experience, that the adherence to these changes can often be difficult because life gets in the way. So what the current guidelines recommend are different behavioral strategies to help. And there is an emphasis on self-management, self-monitoring, stimulus control, and problem solving in terms of how we can counsel our patients. There is not too much research on what is the optimal behavioral change strategy because all of the interventions that have been done short term. So when I talk about a study on diet or exercise, it's a 3-month study or maybe a little bit longer, but we haven't evaluated behavioral change strategies over years. So this is an area of research. But really it is to highlight that it's important to make our patients self-sufficient in terms of making these changes and these lifestyle modifications over the long term. So let's get back to Polly. So she comes back to your office after 4 months, and she had the good luck of meeting with your multi-interdisciplinary team that has an RN coach, a registered dietitian, psychotherapist, and she was able to successfully implement those lifestyle changes. And most importantly, she was able to stick to them. So now her BMI has improved to 26, down from 29. Her waist circumference is down to 80 centimeters down, which was previously 88 centimeters. You send her for some labs, and you see that her 2-hour oral glucose tolerance test has improved to 8.4, which is better from previous, but still does show impaired glucose, as well as a lipid profile, which is normal. Her cycles have improved to every 2 months, but she's still quite concerned about the excessive hair growth on her face and body. And so she says to you, "Help me, doc." I think she's open to considering further treatment options. Um, so, what are our goals of treatment for poly here? So, endometrial protection is key. If she is going long stretches of more than 3 months or regularly not having a cycle, then we do worry about increased risk of endometrial hyperplasia or endometrial cancer. We want to manage her hirsutism, and we also want to manage the impaired glucose. So we can consider something like a combination of oral contraceptive pills, spironolactone, and metformin. And you might start one at a time just to monitor for side effects and tolerance of that therapy before adding on the next medication. And also, of course, you want to assess for the response to that medication. So let's talk a little bit about combined oral contraceptive pills. So I do find a lot of patients do have a misperception of the pill. They are prescribed it to regulate their menstrual cycle, meaning that they think that it is causing them to have regular periods. But I often do counsel them that the oral contraceptive is switching off their natural cycle and that the bleed we're having is a withdrawal bleed. And this is to accomplish many things, most importantly, to prevent endometrial hyperplasia and decrease the risk of endometrial cancer. So the oral contraceptive pill, which contains both synthetic estrogen and progestin, acts in many ways. So number one, it will decrease the LH secretion. It will decrease ovarian testosterone secretion, as well as decrease adrenal androgen secretion. So this can definitely help with those symptoms of hyperandrogenism. Additionally, the birth control pill will increase sex hormone binding globulin. So if you remember, in women with PCOS, they do have a lower SHBG, and when they are on the contraceptive pill, it's going to increase that concentration and therefore cause a decrease in the free testosterone. And that can be a mechanism by which it can help with things like hirsutism. The oral contraceptive pill, as I just mentioned, will help with protecting the endometrium by causing regular withdrawal bleeding. So how do you select a oral contraceptive in PCOS? So the guidelines actually do not recommend one birth control over the other. They do, however, state that there's no benefit of using a high dose estrogen over a low dose estrogen. And the progestin cyproterone acetate is now recommended as second line birth control due to the VTE risk. So cyproterone acetate, if you remember, is like the trade name is Diane. And so that is something that they would recommend as second line. So in terms of selecting a pill, you might want to consider a pill that has less androgenic effect. And so different progestins will stimulate SHBG synthesis differently. So they'll either stimulate it or they will inhibit it. And so the progestins that might be a good fit in terms of minimizing hyperandrogenic symptoms would be things like drospirenone, norgestimate, desogestrel. What is going to be a little bit more androgenic would be norethindrone, and the most androgenic would be levonorgestrel. Another therapy that we can use is metformin, and this is something that you can consider in adults and adolescents with PCOS who have an elevated BMI or other risk factors such as insulin resistance or type 2 diabetes, and it can improve both metabolic outcomes and it can help with cycle regularity. There is limited evidence to support the use of metformin in adults that have a BMI less than 25, but it can still be considered in those women with PCOS. It's important to counsel your patient that metformin and active lifestyle intervention actually have a pretty similar efficacy. If you do decide to use metformin, I recommend starting low and going slow. So just starting at 500 milligram increments, increasing it every 1 to 2 weeks, and just speaking to your patients about the GI side effects that can come with starting metformin. Other therapies include combining the oral contraceptive pill with metformin, and this is most beneficial in high metabolic risk groups. What's kind of new on the block is using GLP-1 receptor agonists in patients with PCOS to help with the weight loss as well as bringing down the insulin resistance. If your patient is on a GLP, make sure that they have effective contraception because the safety profile in pregnancy is not known as of yet. The other option is bariatric surgery. With respect to anti-androgen therapy, if we are trying to treat symptoms of hyperandrogenism, a 6-month trial of a combined oral contraceptive pill alone would be recommended. If that's not effective, or say if your patient is not interested in taking the birth control pill, then you can consider treatment with an anti-estrogen such as spironolactone or finasteride. Cyproterone acetate is not recommended at doses greater than 10 milligrams due to risks, including that of meningioma. It's important if your patient is on spironolactone or finasteride to make sure that they have effective contraception. So that could be the birth control pill or a levonorgestrel IUD or a progestin implant, because if they are on an anti-androgen, it can have effects on the fetus, especially a male fetus. The last option here is mechanical laser hair removal for hirsutism. So this would be how we could manage those symptoms. So Polly comes back to you 10 years later. She has had a successful pregnancy about 2 years ago. And during that time, she obviously stopped the combined oral contraceptive and spironolactone, but she continued on metformin. She tells you that her periods resumed about 8 months postpartum, and she was having cycles again every 2 months. But now, over the past 2 months, she's been having eight days of heavy bleeding and then a week of spotting each month. And she's quite concerned. So to work up this abnormal uterine bleeding, you send her for a transvaginal ultrasound, and it does demonstrate an endometrial thickness of 9 millimeters. So here, what we want to be thinking about is the risk of endometrial cancer. We know that the risk of endometrial cancer is about 2 to 6 times higher in PCOS than controls. And we know that obesity is a major risk factor for endometrial cancer. So if your patient does come with a abnormal uterine bleeding history and does have thickened endometrium or an endometrial polyp, that should prompt a consideration of an endometrial biopsy and or hysteroscopy. So Polly comes into your office, you're able to do an in-office endometrial biopsy. Unfortunately, it is negative for hyperplasia or endometrial cancer. You do send her for sono to evaluate for other causes of AUB, and you do discuss options for endometrial protection and contraception, as she is not planning on conceiving anytime soon, and so she chooses a levonorgestrel IUD. So the takeaway messages from today's talk is that PCOS is a lifelong hormonal and metabolic condition, and that lifestyle management is a core focus of therapy. In terms of adhering to lifestyle modification, this is where we want to look at behavioral strategies and cognitive behavioral intervention to help with sustained kind of adherence to changing diet and activity. Stress and sleep management are also important pillars of lifestyle, and you can use pharmacotherapy when needed to treat symptoms. And the last takeaway is that endometrial protection is important to decrease the risk of endometrial hyperplasia and endometrial cancer. So that's all I have for you guys today. Please feel free to connect with me. I've left my email address there. If you have any feedback or any questions, I'd be more than happy to connect with you. And again, I just want to give a big thank you again to CCH OHT for supporting me on my talk today.
Thank you, Dr. Thakkar. If anyone has any questions, we have some time left over, so feel free to speak with your questions or write them in the chat. Chris?
Thanks. Fabulous presentation. That was a lot of ground to cover in under an hour.
Yes.
It was a really great job. Yeah, and I learned a lot.
Thank you.
Question about sleep apnea in this population. Did the guidelines speak to whether we should consider screening those with PCOS just because they have PCOS, or really look at the Epworth Sleepiness Score as a standard and then just go from there?
Yes, so that's a great question. So it would be to use a screening tool like the Epworth Sleepiness Scale, and if they are scoring positively, then to consider a sleep study.
Okay, but they did speak to the fact that that probably should be added as a routine part of a workup for PCOS, is using a sleepiness scale of some sort.
Yes.
Okay. Thanks.
Any other questions? Feel free to use the chat box, or if you have any patients that you've seen that you wanted to share any experiences.
I have a question about insulin. You mentioned that the assays have not been standardized, but if we did order insulin, and I've had patients request that, is there a best way to order it? And do you know how expensive it is, and whether we should take any heed to the result, or is I presume it's not entirely useless, but what do you know about
Yes, yeah. So I don't think for example, a fasting insulin or a like postprandial after a glycemic load insulin, it hasn't been standardized. So the current guidelines suggest that we should not be ordering insulin assays. And even talking to endocrinology colleagues, they would be in agreement with that. That is not standard practice to order insulin levels, because it doesn't. How can I best put this? Is there is no kind of like, definitely your lab will give you a range of what might be an adequate fasting insulin, for example, but it's not diagnostic of insulin resistance. I know there's discussion of using like the HOMA-IR index, and a lot of like the clinical research is based on the HOMA-IR, but again, in clinical practice, it's not something that's recommended. Just because there's lack of standardization and there's no definitive way to say that this person is in fact insulin resistant. So I would say probably the best bet would be to use like a 2-hour oral glucose tolerance test to get a sense of whether there is like glucose dysregulation.
That's helpful, because that's a common question we get. So
yes,
we go to them.
Yep. Yeah, I get asked that all the time as well, and I mean, I hope that we do start to develop maybe a little bit more testing around that, but I think again it's just an area where we just need more research.
I have a question around cardiac risks. So is there any specific recommendations in the guidelines around like screening for cardiovascular risk in women, or is it just sort of case by case?
Yeah, so in terms of screening, they do recommend if there are risk factors in women with PCOS, such as elevated BMI, or if they have like a family history of diabetes, acanthosis nigricans, kind of those findings that we should screen using blood tests and also clinical exam. So just in terms of monitoring like your traditional cardiac risk factors, so blood pressure, waist circumference, lab work such as what we discussed in terms of like a glucose tolerance test, which is recommended over an A1C, as well as like a lipid profile. So it would be kind of how we traditionally screen for cardiovascular risk factors, but just kind of having your antenna up when it comes to women with PCOS. And in my clinical practice, anecdotally, I do see a lot of young women coming in with very elevated A1C, so like in like the pre-diabetes range, and that's where I'm a little bit more like vigilant in terms of keeping on top of screening or making those recommendations.
Okay. Thank you.
Thank you.
Any other questions or final comments? I think we're good and we're on time.
Awesome.
Thank you, Dr. Thakkar. Thank you, everyone who's joined. And yeah, we hope to do more talks starting September. Probably take a break over the summer. I'm sure everyone's busy over the summer, but we'll also be sending out a survey to gauge interest on topics that we would all like to hear about. So stay tuned for that. And yeah, see you all next time. Thank you.
Thank you, everyone, for joining.